Hey guys, Nick again, here to help you tackle the respiratory physiology section. Lots to cover, so let's get to it. Lung volumes are super high yield and are guaranteed to show up on your exam, so you should know them backwards and forwards. Establishing a solid understanding of these lung volumes will not only translate to well-deserved points on the exam, but will ease your mind about the exam as a whole because of how often these are tested on. Once you have them down, practice drawing out the graph we're about to cover, so come exam day you'll be able to quickly reproduce it on your marker board. First, let us define some terms. So what are the important parameters? Let's go through this by using the graph. Lung volumes are these four individual measurements. You have volume graphed over time. The inspiratory reserve volume is the amount of air that can be inhaled after a normal respiration. The tidal volume is the volume of air that moves in and out of the lung with each normal respiration. This is an important parameter when establishing the efficacy and therapeutic nature of mechanical ventilation. The expiratory reserve volume is the air that can still be forced out after normal expiration. That's when you blow out as much air as possible. I like to think of it as the low tide mark, where the water on the beach is the air in the lungs. It's as low as it's going to get naturally, but there's still some water left in the bay, like there's still some air left in your lungs after you force everything out. Now what do we call the leftover air in the lungs after maximal expiration? Correct, residual volume. Now check out this mnemonic, liter. Lung volume, inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. So what factors affect lung volumes? Lung volumes tend to be greater in tall people, smokers, and people who live at high altitudes. For example, in COPD, an obstructive lung disease heavily associated with smoking, the patient cannot blow out as much air of the lungs due to the obstruction of the airway. Can you guess one of the lung volumes that is subsequently increased in this disease? Residual volume, because there tends to be more leftover air sitting in the lungs after a forced expiration. This is sometimes referred to as air trapping. Keep this in mind. We'll revisit this concept again here in a few minutes. Now it's also important to understand how the different lung volumes are related to each other and how each can be determined. A capacity is made up of multiple volumes. The inspiratory capacity is the tidal volume plus the inspiratory reserve volume. Functional reserve capacity is the volume in the lungs after normal expiration. So if that's the case, which volume comprises the functional reserve capacity? Correct, the expiratory reserve volume and the residual volume. The vital capacity is the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume, basically everything except the residual volume. So it represents the amount of air you would breathe in if you first exhaled as much as possible and then inhaled as much as possible. Okay, finally, how do we determine total lung capacity? Well, it's basically everything. So in COPD, will the total lung capacity be increased, decreased, or will it not change at all? Well, it'll be increased. Remember, air trapping occurs in these obstructive lung diseases, which increases the residual volume and thus the total lung capacity. Lung volumes are important in the diagnosis and management of many lung disorders, and likely to appear on step 1. So let's take a look at how a question might be posed. You see a 55-year-old coal miner with a long-standing cough and progressive shortness of breath. He has inspiratory crackles, and you see patchy bibasilar interstitial infiltrates on chest x-ray. So what would you expect the lung volumes to look like on pulmonary function testing? Well, this is likely a case of anthracosis, or coal miner's lung. As we'll discuss in more detail soon, this is a pneumoconiosis and a restrictive lung disease. In contrast to obstructive processes, restrictive lung diseases are typically characterized by decreased lung volumes, including total lung capacity. Recall from our respiratory anatomy talk that dead space does not participate in gas exchange. So what's physiologic dead space? Well, it's anatomical dead space from the conducting airways that we talked about in the respiratory anatomy section, plus alveolar dead space. So what is alveolar dead space? Well, that's where you have alveolar ventilation, but no perfusion, so therefore no gas exchange. The apex of the lung is an example of alveolar dead space, where air is inspired and filling the alveoli, but no blood is flowing through the capillaries to participate in gas exchange. Now, why does this happen at the apex? Well, this is due to gravity. Anatomic dead space tends to be fixed, but alveolar dead space can significantly increase in conditions such as COPD, where you get a classic ventilation-perfusion mismatch. In a ventilation-perfusion mismatch, or otherwise called a VQ mismatch, where V is ventilation and Q is perfusion, there is more wasted ventilation, meaning that there's a larger percentage of air that's inhaled but not able to participate in gas exchange. It's simply just taking up space, alveolar dead space in this case. However, in some instances, the alveolar dead space will decrease, such as during normal exercise, when the upper lobes are more heavily perfused for maximal gas exchange. Physiologic dead space can be estimated by using the Bohr equation, where Vt is the tidal volume, PaCO2 is the arterial carbon dioxide content, and PeCO2 is the content of CO2 in expired air. This makes logical sense because only ventilation involved in gas exchange produces CO2. The closer the PeCO2 is to the PaCO2, the less physiologic dead space ventilation you have. As this difference decreases, more of the carbon dioxide in the pulmonary arteries is being expired with each breath. You can keep this all straight with the mnemonic taco paco, peco paco. Ventilation is the movement of air into and out of the lungs. It has a specific mathematical definition defined in two different ways: the minute ventilation and the alveolar ventilation. The minute ventilation is the total volume of gas entering the lungs per minute and is defined as VE equals tidal volume times respiratory rate. However, this is different than the volume of gas that reaches the alveoli. Now, why is this? Because of dead space, mostly. Can you think of a pathology that would decrease alveolar ventilation? That's right, any obstruction that would limit aeration of the alveoli, like cystic fibrosis with mucus plugging. Alveolar ventilation is described as VA equals the difference between tidal volume and dead space times the respiratory rate. Flash quiz. Which letter represents the functional reserve capacity? F, the volume in lungs after normal expiration. Let's now talk about some lung mechanics, specifically those that rely on the lung's compliance, or how well the lung can change volume in response to a certain change in pressure. This graph represents the pressure dynamics between two tissues, the lungs and the chest wall. The blue line represents the chest wall force, the green line represents the lung force, and the dotted line in the middle represents the sum of these two pressures. Let's take a moment here and agree that this graph is a bit intimidating and at first glance may not appear all that intuitive, but let's walk through this together so you'll be ready to handle these types of questions you'll get on the exam. If you look at the x-axis and move right, you're going up in pressure. This increase in pressure has a linear relationship with lung volumes, which is the y-axis. So as the pressure inside the lungs increases, the lung volumes will increase as well. When airway and alveolar pressure are zero on the x-axis, this is called atmospheric pressure. The measurement used to describe this state is the FRC, which stands for functional residual capacity. Now, at atmospheric pressure, the chest wall's force is described as an outward pull on the lung tissue. So the chest wall has a natural tendency to expand or grow in diameter in the anterior-posterior direction. But there's something that's opposing that expanding force. Can you guess what that is? Correct, the lungs. Now quickly, what's one disease process that might cause a type of pathologic chest wall expansion if the lungs weren't functioning properly? Correct, emphysema. In emphysema, there's an increase in the AP diameter of the chest because there's actual destruction of lung tissue. The chest wall's outward pull is left unopposed. So what's the term used to describe these patients? Absolutely, pink puffers. Now, the lungs have a natural tendency to collapse or create an inward pull on the chest wall. If the inward pull of the lungs was unopposed, what would that create? Well, that would create a pneumothorax. The lung wall would collapse on itself if the chest wall's outward pull wasn't there to equalize the lung's natural tendency. So when you're breathing, there is a tendency for the lungs to collapse inward and the chest wall to spring outward. When the lungs are at their functional residual capacity, the inward pull of the lung is equal and opposite to the outward pull of the chest wall. The system pressure is the same as atmospheric pressure and there is no net air movement. At this point, the airway and alveolar pressure are both zero, and intrapleural pressure is negative. By the way, why is intrapleural pressure negative? Well, negative intrapleural pressure keeps the airways open. Now this directly ties in with the concept of compliance that we mentioned earlier. Compliance is defined as the change in volume for a given change in pressure. So higher compliance means that the same pressure will create a larger volume change. Now what's the inverse of compliance? Well, that would be stiffness. The slope here is the measure of compliance. As you can see, where the slope is steep, you have the most compliance. You tend to have more stiffness or less compliance with extreme volumes, and therefore you see a flatter curve. So if you have a patient in your ICU who requires ventilator support for adult respiratory distress syndrome, or ARDS, will you typically need higher or lower positive airway pressure to ventilate their lungs? Well, in ARDS you have pulmonary edema, which makes their lungs stiff and non-compliant. You're going to need more positive airway pressure to get the same tidal volume, and you will see a flatter volume pressure curve. Clinically, the amount of positive pressure can be so high that it may actually cause trauma to the lungs. This is known as barotrauma.